Hi everyone, my name is Saeed. I'm a co-founder of Tranquil. Today we are having an interview with Dr. Sanjay Rao. He is a psychiatrist and also a university prof at University of Ottawa in Nova Scotia. We're going to have a very interesting conversation around the therapist-client relationship and elements of that relationship. And with that, I'm going to ask Dr. Rao, please introduce yourself.
Thank you, Saeed. Of course, as you introduced me correctly, I'm an associate professor in University of Ottawa and University of Dalhousie. I'm also a clinical director of the Mood and Anxiety program at the Royal Ottawa Hospital in Ottawa. A lot of my work involves doing routine clinical practice, but also teaching and training people in psychological therapies like cognitive behavior therapy. And I've worked in many places. A lot of my experiences have come from UK and from Nova Scotia and now in Ontario.
That's awesome. Well, I think comparing your experience in all these different places itself could be a very interesting topic for another interview. But that's one of the reasons I personally was very interested to get your perspective on the topic is actually like the fact that you have this diverse experience of working in different setups and with different populations. So I'm very much looking forward to it. Dr. Rao, I want to start this interview with my very personal question about being a therapist. Because I think it's a very very hard job to do, and I think one of the hardest aspects of being a therapist is maintaining a balance in their practice. So a therapist has to show empathy and quote unquote care about the problems that a client or a patient would represent, but at the same time would need to maintain a distance to from the situation, from the client, to be able to always make the best recommendations and the best suggestions. So, Dr. Rowe, can you talk to me a little bit about this balance as a psychiatrist? How do you maintain this balance, and how do you maintain this distance? And as a teacher, what are the things that you teach to your students about this maintaining this balance and this distance?
Okay, so there are two questions there, Sayed. So I'm going to try to answer them in two parts. First part of the question is how do you maintain a balance between caring and being empathic to the client and keeping some sort of some sort of boundary. So strangely, that has not been a problem for me personally, and that may have to do with my orientation towards my work and my training in the types of things that I do. So if we think of the client as a person, and the person comes with a certain question or a problem or is stuck in some way, to me it makes no difference. You could be going to, say, get a mortgage or advice or any of this. So you go as a person and you bring your question. So in the first place, I see that there's a person and there's a question. Mm-hmm. So it's important to know a little bit about the person and then know a lot about the question. So the client is here to really have some kind of resolution to the question. So I keep the focus on the question and some attention to the client's background behind that question. Mm-hmm. And that way I don't seem to have a difficulty in getting drawn in different directions. I'm able to keep my focus. I've seen excellent examples in my clinical practice with people, and I suppose that has influenced me. But I've also seen people in different walks of life, like a good plumber or a good salesperson, or a good telephone support person, they all have the same perspective. They're quite respectful to the client, but they're also trying to find out what might be the best way to help them. So in that sense, I don't see my job as any different from that kind of customer service. So now coming to the second part of your question, which is how do you teach this to people? And that's really interesting. The people who might teach are already in the medical field or healthcare field in one way or the other. So my assumption is very positive that they already know something about this kind of separation, be it artificial, between the person and the difficulties they're coming with. My main job is to help them understand the pattern of these difficulties and how to collaborate with the client. And in doing that, there doesn't seem to be any draw to move away from that task. And I've not had to actually get people to change their practice or pull back in any way. I actually listen to people's audios and see their videos. I think it's just a style of work. It's a collaborative relationship, and collaboration means joint problem solving. All that stuff which we do in CBT is automatically very helpful in that sort of approach.
Mm-hmm. So it's interesting because I think like part of, as I mentioned, this was like my personal question, and maybe like this question comes to my mind a lot because I'm not myself a therapist or a service provider. And you mentioned a very interesting point that this relationship, the nature of the relationship is the same way as the relationship of a plumber and their client in certain ways, but I'm sure there are various specifics to this relationship. So can you please explain a little bit about the elements of a client-therapist relationship? And can you and I want to really dive into some details of each of those criteria, of those elements individually. But can you just like give us a little bit of overview of what are the elements of that relationship?
Okay, so that's a good question. And depending on which school of therapy you go to, there might be slightly different answers. So I'm going to try to answer that generically first. Generically, in terms of client and therapist relationship, first of all, it's mandated by the profession. So it might be the medical profession or healthcare profession. So there is a certain amount of professionality which is expected in the relationship. Both the practitioners and clients actually know this very well. So when a client walks into the room, that's not a struggle. I mean, the client knows they've come to see a doctor or a therapist. Therapist knows what their relationship ought to be with the client. So there's already some kind of foundation there. The second part is that when people are coming to us, we obviously have to be respectful of their perspective and background, even if they are quite different from us. So I've changed countries a number of times. I meet people who have had completely different backgrounds and upbringing or professions or social life or hobbies or interests compared to me. But over a period of time, to develop that kind of interest in people who could be completely different, or coincidentally could be this very similar, but that similarity or difference doesn't sway how you interact professionally with a person, and how it should feel to the person that, like, hey, this person is interested in my life. And actually, sometimes not knowing a lot about clients' life is useful, because then you can actually show genuine interest to understand about their life. So that's one. I think the interest in the client's life and problems is really, really important. So that's one aspect. The second aspect, which I think is really important, is knowledge of the client's problems. So you can imagine, you could have the best intention in your heart, But if the client comes up with problems which you do not have the expertise or problems, you're going to struggle with it. And that struggle will affect the relationship. And I think clients will be sensitive to the fact that you are struggling in the session with them. So I do my best in my training and in training people that I learn a lot about the kind of situations clients find themselves in, the kind of problems they come with, so that when they come up with those things apart from interest in their life, I can show some confidence that I'm able to work with them on this.
So you mentioned two interesting factors: is an interest in the client's life and their journey on the therapist side, and also the competence that the therapist can actually make an impact in the client's life and would hopefully help them to live a better life. So, but on the client side, I'm thinking the client invests or the patient invests time and energy into the process. So as a client or a patient, like it takes time to seek help, to go and find a therapist, to book the first session, to commit to the process. And I'm instantly thinking of an interesting terminology. Maybe like one would think about return of investment, because it's really hard and challenging, I think, for a lot of people to think of the benefits of doing therapy, because the benefit is actually deferred to a future time, and it's sometimes challenging trying to visualize how these benefits would be. So can you talk a little bit about first of all, do you even like agree with this type of like looking into this problem? I mean, from return on ROI, putting an ROI glass on, and also, if so, like what are the best ways to convey this the benefits of therapy to the clients if I'm a therapist?
Okay, so I think the question is very well stated and an important question, and I think it's best for the listeners to illustrate this with a specific example. Otherwise, it'll sound very abstract. So let's say a client comes with depression. Of course, it could be a client with anxiety, but let's say a client comes with depression or depression and anxiety. So my first job is to connect at some level with the person. So, and the way I do that is to ask them not so much about the depression and anxiety, but what is it that brings them to see us? Because we want to hear a more personalized account of their problem. So they come here because they can't work or can't attend to the university or can't drop children to school. So what are the sort of pressing things in their life which have become difficult? That's the kind of interaction I want to create. In the background, I would ask, even before we start, about simple things like where they live and how long is the commute and where they parked. I mean, these are the sort of things which build up some kind of interest in the person, and the person knows that I'm taking interest in their life in general. Well, it actually gives me very valuable information about the person's background, and I won't go into that just now. Then going into focusing into why they're here and asking them very directly what is their most important questions and what are their best hopes from the session with. So in some ways, I'm already primed to understand what would make this person feel that this interaction was successful. So they have a question and they have some expectation. And if they don't have a question, then I would ask permission that we should work on fleshing out a question which would be important for them. So that's the start. So let's say this person comes with depression, and I would find out a little bit about themselves and then why depression is a problem in their life, and then they would illustrate with how it's affecting their life. Then I'll go on to sort of getting more information to analyze the overall pattern of depression and the trajectory of depression. And that's really where the punch lies, because not all depression is the same, and not all people are. I mean, people are different, and their depressions are different. But with expertise, you can see there are different patterns to it. And knowing that then gives me some kind of initial overview of formulation to show to the client that, look, this is how you're getting stuck. This is the overall pattern. And these are the evidence-based ways of treating these problems or managing life better with this. And I often use a lot of visual tools to do that. So I sit with a client in such a way that I can either use a pen and paper between us, or I would have a whiteboard and I draw out and map out some of the problems and how it's affecting them and what are the ways of working with them. And most of the times, I've had fairly positive feedback in the first session itself, because people feel that, maybe there's a way out of this. And even if we have achieved that in that session, I think that is quite a lot for the person to take away, that there's some hope. So that's what I try. I don't try to overachieve in session one. I just want to convince them that I can understand their perspective. I would like to show that there is a way out of this, and just take away that high-level view that we can work in a systematic way.
And it's just like worth trying, giving it a try.
And that is worth giving it a try. I often give them something helpful like, here's what the research information shows in terms of what this therapy or this treatment does when people come with such problems. Or I might say specifically that, okay, if this is the issue and this is what you're unable to do, like go to school or work, that could be part of our work together, so that you're able to sort of get back to doing these things. And in these ways, subtly, we are giving the hint that it's not just about treating a depression, it's about working to get your life back in balance. And these are the specific goals we could work towards. So somehow I have never had a problem with that, because clients automatically identify that there is some way, and there is some method, and there is some way I can become more empowered in dealing with it.
It's and then you mentioned that the actual a lot of times clients are self-expressing that they know something is going wrong and they know there is another way of living. But a lot of times, clients might actually are in the situation, or the patient is in a situation that they can't even have an idea of that alternative way of living or alternative way of feeling. And you mentioned visualizing this journey for them, which is very interesting. Can you just a little bit elaborate on that?
So there are 2-3 approaches to this when we look at people in the first session, and there are multiple approaches to visualizing issues in subsequent sessions. So in the initial session, I like to look at the trajectory of the client's life before the problem and after the problem, and if it's a repetitive problem, how each episode affects the person, where is it in relation to their life phase, etc. And I try to depict that visually. And that itself is a very helpful summary to the client, because A, they think that, I'm interested in trying to make sense of it. And B, if there is something which I have not understood well, then they can point out, no, this is how it worked out at that time, or, oh, I forgot to tell you that this is what it is. So using those kind of visual tools helps us have a collaborative understanding and jogs the client's memory too. So that's first part. I use other tools to look at, can we put together the things which are adversities in client's life and those things which are supporting this person. Now, it could be their own personal strengths and characteristics. It could be uh, people in their environment and their close ones. So trying to get a balance, a net balance of, okay, this is what you want in life or is important for you. This is what is pulling you down, and this is what's supporting you. So those kind of things are intuitively very, very interesting for people because they haven't really thought about these things in this way. And the fact that therapy can assist, enhance this balance so that your own natural strengths and resources can actually help you towards recovery. So that's kind of how I try to use visual tools in the first time I meet the client.
So around that interest in knowing the client's journey, and as you said, how their life looked like before this particular issue, and how they looking like right now. You have to build like some intimate relationship with the client, as you mentioned in your first session, trying like and show some genuine interest, which really brings us to a topic that is a concern to a lot of providers, psychologists, and social workers, and of course psychologists, that they're sometimes overly concerned with boundaries. What is that like right level of getting close to a client? Like there is like a huge debate around conflicts of interest, sexual confusion. There's even like a debate going on whether or not a therapist should go on a walk with their client. So, Dr. Rao, how close is too close?
I'm really surprised that this question keeps coming back in therapy practice. First of all, there is a code of conduct of ethics for each licensed profession, and that actually adequately covers what the professional conduct should be. And I have not had occasions to really be very concerned about this, at least in the practice of therapists whom I supervise. But we can break this down further. Now, we have different roles in life. So if you have children, you relate to your children in a certain way when you're at home. You relate to them differently when you're outside. Similarly, you could have colleagues, and you might have friends. You might have colleagues who are also friends. And depending on the situation, your role automatically slightly changes. And that's okay. It's very, very helpful to have that kind of flexibility. So the client-therapist relationship is also that a particular type of relationship. So things like what sort of intimacy and how close is too close, or physical relationships, these things we automatically know just as much as we know that which way is up and which way is down. We automatically know what ought to be the typical relationship in these situations. Now, I have, of course, come across situations where it was not that way. And it is concerning. It doesn't happen very often. And I think part of that has to do with therapist competency. I don't believe it's to do with the personality of the therapist, because people with different kinds of personalities become therapists. So if the therapist is competent, they know the level of closeness and distance which is needed in a particular type of therapy. So let me give you an example. If I'm working, say, with a client through dialectical behavior therapy, which is a very intense form of cognitive behavior therapy, and the client is suicidal, they can call me at times outside of therapy hours to be able to coach them how to deal with things. Now, that I would do in dialectical behavior therapy, I would not do when I'm doing cognitive behavior therapy for, say, panic disorder, because that's not part of that deal. That's not the model to work on. Let me give you another example of another style of cognitive behavior therapy for chronic depression called cognitive behavioral analysis system of psychotherapy. in this therapy, you're allowed to make certain kinds of personal self-disclosure to the clients, and the clients can ask you questions, and you might do some personal disclosure. But the purpose of these disclosures is not to indulge the client or yourself, but the purpose is to be authentic, but also technically competent. So it is done in a very disciplined way. So the self-disclosures, the style of concern and intimacy, which is shown for the client, is done in a very systematic and disciplined way. And it's important because without that, A, it wouldn't be serving the client, and B, it may be harmful to the therapist as well.
So you mentioned different roles that people take in their lives. I park that concept because I do have another question about that. But you mentioned like the people like know different people in their life and they're coming from like a different backgrounds, and the therapist is should be of course competent to figure out where is that line. And I do agree with you. It might basically be natural, but again, like it's very important because like people come from different cultural backgrounds and they have different social norms that basically define their boundaries around them, and what might be worth looking into to on the therapist side to be mindful about these cultural differences. But a particular issue that might come into mind in mind is where literally the the therapist would know people around the client. I'm talking about specifically rural areas. And in those areas, actually, this boundary issue might be more of a concern to the client population or rather than the therapist population. But in a very small town, I, as a client, might not be comfortable with the idea of seeing my neighbor's relative who happen to be a very, very competent therapist. But it's just, I have dual relationships, and it's just like that's something that is concerning to me, might be concerning to me. Can you talk a little bit about that as well?
Yes, and this is a question which I've faced several times, especially in Canada, which is relatively underpopulated, and people live in pockets of small communities. And I have worked in such communities as well. So, and that's why sometimes people advise that where you work, you shouldn't be living there in that same area. However, what practically happens is, if you go back to that example of different roles, you might have a colleague who's your friend and also a colleague, and you work with, and how you interact with that colleague in different environments is different. So it's the same with the client. The client in your therapy setting and the client as a member of the society in a social occasion are two different roles. And it is a hard balance because obviously therapy is a much more intense relationship. So it is a harder balance, and there can be some awkwardness. And people have told me about it, and I've experienced it myself, that we have to be very cautious in such situations. Mm-hmm. And maybe now that we have technologies like what Tranquil has, that's giving us some answers that, hey, I can choose to have my therapist somewhere else. And at least whatever research we have is that video interface type of therapy is as useful in terms of therapeutic relationship. It doesn't seem to impair the relationship between client and therapist. So here's another alternative option, to choose a therapist who is from slightly away than where you live.
I can't agree more. It's the technology enables us to explore areas and do things that was seemingly impossible, and it's in particular. I agree that just creating the option for the members of the community to have access to someone who is maybe lives like slightly away, as you mentioned, would actually like help at least a good population, a good percentage of the community, members of the community who have this challenge in mind. But uh, if you want to like translate that boundary issues and boundary problems into the digital world, into the video conversation, of course, like it's like much harder to draw the line, but also it might actually practically be harder to violate any of those boundaries per se. Like there's not an opportunity even for a physical interaction between a therapist and client. But how would you basically translate those ethics, those professionalism into the digital world, into the online world, into the video therapy?
Um, these are, of course, some new questions which are coming up, given that we are having more and more online interactions, not just in therapy, but in many other areas like customer service, etc. So the data so far is very positive. If we do one-to-one therapy online using camera interfaces versus actually sitting in the session, the outcomes don't seem to be very different. Of course, we have to consider some practical issues, like if you're dealing with a client who's suicidal, there's not much you can do if you're not in the room, if there is some factors need to be taken into account into managing safety, etc. But barring those exceptions, clients seem to respond very well to this. And there is, of course, this kind of natural protection that breaching of boundaries, at least physically, inadvertently, like through touch, etc., is just not possible. I'm not as cynical, though. I mean, I think even in person, people probably most often don't breach those boundaries. When they do, it becomes sensational. But in an online interface, that just isn't possible. But there is another thing with an online interface, and having used it a lot in different types of online interface, I find that it brings a certain kind of focus to the interaction. So you can imagine, like, when you meet people in person, and then when people contact you by phone, I'm meaning your friends and family, very often the conversation can be much more focused when you're using a distance medium of interaction. And I think that's really helpful in therapy, both for the client and the patient. The second advantage in terms of purely the technical interaction is that when clients come to meet us, they have taken the trouble to travel, etc., factor that cost. But they are in an environment which is not their own. So they are in a different environment. Whereas when we are talking to them over phone, telehealth, or interfaces like trunk, very often they can still afford to be in their own environment. So, some of the feelings which they may generate may perhaps be more representative because they're in their own environment. And we can see that better. So, there are some very distinct advantages of having kind of distant therapies which can go right into the client's home.
So, going back to you mentioned the roles of people, right? Going back to that topic, that people have like different roles, like the role of a friend, and then they put different hats on their during their day-to-day life. But I want to actually take it one step further and then talk a little bit about the role of therapists in the client's life, because a lot of times actually like therapists try to basically name themselves as a friend that you can just talk to. Well, it's or which I personally disagree. Or a lot of times even the clients think of their therapist as a friend or teacher, because I think that's the closest role that they can sort of like relate to as the role of therapist. Because it's really hard to justify that I pay my friend to talk to him or her, and it's not justifiable to expect my friend to have the competence and the expertise to be able to interpret my life situation, my life problems, and come up with the right suggestions or unbiased opinions and unbiased solutions. So, what are some of the healthy ways of communicating the therapist's role and identifying their role in a client life?
So let me sort of answer this with some kind of example or model. And it differs from therapist to therapist, client to client, and the model of therapy as well. So there are complexities here. But let me give you a very simple example. Now, I've had experience, and I'm sure you would have had experience too, to go and buy something simple like, I don't know, vacuum cleaner or stereo speakers or something in Best Buy. Or some other, and I'm not endorsing Best Buy, but or some other, chain. And you notice, and I have noticed this myself, that different people who are there to help you in sales, they have slightly different approach to it. But all that is well within their sort of professional work, but also they're very amicable, which the client can identify with. So when a client comes to see me, I'm trying to bring that kind of, if you like, authenticity that I'm really interested in helping you live a better life. And if that can be communicated, whether they perceive me as a friend or not is not that important. All I want to do is make sure that we work in a collaborative way. And if you start working in a collaborative way, that's comfortable enough to get this important job done. But if I'm spending a lot of time just being likable, then it may distract me or detract me away from the job at hand. Perhaps sometimes the clients are also in that situation. They want to be likable too. They want to be the person who you would like or respect, etc. So somehow we have to communicate that is not important. They're here because of certain areas in their life which is not working out the way they wanted it to work. We are here because we like this work and we can help them in some way. So there is friendliness, but friendliness does not always have to be friendship. And then there's the issue of competence. So whether the client sees me as a different person from they are or not, as long as they feel that I have a level of competence and confidence to understand their problem and work with them and even push them to actually make things better for themselves, I feel we have a much better chance of moving forward than only focusing on likability or friendliness. So that's how at least how I look at it. Now this can change depending on the type of therapy and personality of the therapist. So you might have a therapist who is very focused on relationships naturally as a person, or you might have a therapist who's very introverted and is different from that social extrovert therapist. What if they know a particular model of therapy well, let's say cognitive behavior therapy or dialectical behavior therapy or interpersonal therapy? The model is very protective because irrespective of their personality, the model will guide them what would be the right and competent things to do in these situations. So knowing a therapy model well, which is particularly has evidence for that problem, is really helpful in creating that kind of competent safety zone, if you like. And the clients would respect that because they can see the therapist's competence fairly quickly as they walk through that. So I don't know whether I've fully answered your question, but the issue of connecting with the client and the issue of competent therapy are related but separate issues.
Yes, actually, it's you mentioned that it's easy for clients to see that confidence or to feel that confidence that this therapist is going to help me to figure out like a particular problem or to help me to live a better life. But I'm gonna actually ask quite a radical question, because clients are coming to you with a perception. Or at least that's how I think. Like they think as a client, uh, they basically are under the perception, or under the assumption that they're gonna get better, they're gonna feel better at the end of this process. Uh, are they entitled even to have this feeling, or even if they like, if so, like, is it fair to assume that if they don't see that connection, they should change their therapist?
So that's a good question, and the best way to answer is think about changing the therapist. There should be some clear criteria, which is more than just liking or getting along well initially. Although that can be helpful, I think changing therapist is an issue which should be undertaken when the client is not getting the outcomes they came for. That's really important. So, strangely, I have not faced this situation very many times. I can count the number of times where maybe 2-3 times when the client and I have agreed that they should see someone else because with me they've gone as far as they could, and I could recommend somebody else who could probably work better with them in terms of personality match, etc. And there is some amount of research which is going on, should we be personality matching clients with therapists. However, in practical terms, it's just not possible. There are more clients than there are therapists, so inevitably the same therapist will have to see clients which are quite different and sometimes very different from them. So that's the practical issue. I really want to get back to the issue of learning therapy models well. There is a sense of ease which comes with knowing a therapy model well. So to give you an example, I've trained a lot of people, and people struggle. New therapists struggle with dealing with, say, obsessive compulsive disorder. Quite typical. But I have had occasions where a new therapist would be struggling with a client with obsessive compulsive disorder, and as they become more competent in their skills of dealing with obsessive compulsive disorder, they're no longer struggling, and you can hear the ease of relationship within the therapy session, simply because the therapist has now become more competent in dealing with that type of problem. So we're always thinking, there's the therapist personality which matches the client, and there's the therapy part. But what if there's a reverse relationship? The fact that you're able to do your therapy well in the specific area starts affecting how you relate to the client. And that's what I try to do in my therapy training with my training, is to give them that message that, hey, if you've become good at it, you'll get along well with different types of clients because you know the struggle they're going through with this problem.
Yeah, and like you mentioned, like these different modalities. There's usually like certain, if a therapist is following a specific modality, like cognitive behavioral therapy or dialectical behavioral therapy, there are a certain number of sessions like that is usually like assigned to these therapy processes. Well, that instantly brings us to terminating from a therapy process. Well, Dr. Rowe, how would a client know that that he or she has got enough therapy? Like how much therapy is enough if therapy? And is it like a decision that should be even made by the client, or do you think the client should ask the therapist to tell him or her that okay, it's enough? Like how much is enough therapy? Like how would one know?
Okay, so this question often gets asked in health service settings, for example, because mental health in most places in the world does not have enough resources to deal with the problems which are there in the community. So the question is how much therapy is enough is very important because there are lots of people waiting to be seen. have information from different clinical trials. So we have a rough idea for, say, depression, panic disorder, PTSD, social anxiety, like what were the number of sessions needed for treatment, say, with BT or DBT. Now, those are rough approximations, but they're good approximations. Having some approximation is better than not having any. So we can communicate that to the client in the beginning. That typically, in these kind of situations, this is the type of therapy and the number of sessions which is found. But we can review it, say every 3 to 5 sessions to see whether we are working at that pace. If we agreed on 10 sessions, we can review at 8 or 9 to see whether slightly more sessions are needed, or review at 5th session to say maybe we don't need all of those 10 sessions. Maybe we can finish the work a little bit earlier. So it's good to take, it's good to have an overview for the client right in the beginning, and then it's good to agree that from time to time there'll be checks to see whether we are going to sort of need less or more.
In terms of those, like less or more, that is it like a particular indication, like that? I mean, the best practices that are out there that tells us like that. Okay, like this particular problem is now resolved. And that's question. That's one question that I have. But I also want to close this interview with another question. That, like, let's say that indication is met, and as a client, I've got enough therapy, and I'm ready to terminate from this process. Many people think that the therapist and the client should stay in touch, and after the therapy process. Can you talk a little bit about that detachment process, and what's like some of the best practices to pursue in detaching from a therapy?
So an easy way to think about this is to think of the therapy as project. And if you take up a project, and you being an engineer, you would know this well, that projects need to be managed, and there is a project management. Of course, therapy is not exactly like project management and Gantt charts, etc. But we have some similar processes, certainly in evidence-based therapies like CBT and IPT. So it's a project for the client and the therapist. And project has beginning and end. And several reviews to see whether we are working in the direction that we set. One of the really important areas to mention here is not just outcomes in terms of symptoms or emotions or depression or well-being, which are those outcomes which are internal actually to the person, but functional outcomes. And what do I mean by functional outcomes? There's increasing concern that we should be looking at is clients functioning in different areas improving. So it could be their social life, it could be their work life, it could be their family life, it could be their education, it could be their day-to-day skills like getting up and showering and cooking a meal. So those are also valid goals and measurements to look at outcomes from therapy. So having two kinds of goals. One is goals related to the symptoms and experience of the distress, and goals related to outcomes in terms of concrete things in people's lives and roles. Those are the two kinds of goals we can work towards, and they give us together some kind of objectivity how our progress is towards. And like a project, we can see that the project is coming to its final stages as we see that these goals are, progressively being met. So the second part of your question was about termination, detachment, therapist staying in touch with the client. I see again there are two parts in this question. when I was asked this question, when I was last teaching students who are psychiatry residents, I tell them life is beautiful because it comes to an end. Life is a time-limited thing, and therefore we value it. But I think it's the same thing. I think therapy, which is effective, is by nature time-limited. So you can imagine, no matter what problem you have in life, if you give it a year or 2 years or 3 years, you are going to change as a person. And if you want any intervention, it has to do better than the natural change which happens to people. So the intervention has to be time limited, and it has to achieve those goals in that time limited way. So time limited therapy is definitely the order of the day. Most of the effectiveness of therapies which have been done have been in time limited therapy. So that's my model of saying that is effective. The second part is how do you actually terminate? And I actually don't like termination because it reminds me of trains terminating in stations and not going any further, or almost like terminal illnesses terminate life in some way because of the illness. I don't see therapy, and certainly in CBT model, I feel that termination should not be used. Because CBT in therapy, therapy in CBT continues beyond the patient and therapist stopping to see themselves, because the client takes away the skills and uses on a regular basis in their life, almost becoming like their own self-therapist. So the therapy doesn't really end in that. It just takes a different shape. That's what I try. That's the dialogue I have with the client right in the beginning, that this is the whole purpose of therapy. Okay, so keeping in touch, that's a question which can be answered by looking at what the literature is showing us. So, and it depends on the condition which is being treated. As a baseline, just keeping in touch once every 1 month and 2 months or 3 months as a routine follow-up, I'm not sure what specific outcome that would lead to. Now, it would lead to a purpose that you're finding out whether the client is doing well in life or not, of course, but I'm not so sure what outcome you're hoping for, because anything can happen in the gap of 1, 2, 3 months. So there's nothing great about this few appointments based very far in that sense. However, what research is showing is that, say, in conditions like recurrent depression or some types of more chronic type of problems, so if somebody has, say, more chronic OCD, for example, it may be worthwhile to have contact after the active period of therapy is done. And here's the reason. So in recurrent depression, booster therapy sessions may decrease relapse. Or in subsequent sessions, you may work on a specific relapse prevention plan. So all these things are really worthwhile things to do. But that has to be specified and outlined as to why and what is the goal of having those contacts, rather than, hey, I just want to know how you're keeping, so why don't you come back after 2 months or 3 months? Seems like a good idea, but what does it really achieve? The patient can just give you a call and tell you whether they're keeping well or not, or send you a postcard, for example. All those things can really suffice. So if we want to have contact after the therapy is finished, it should be with a specific purpose of reducing relapse and practicing skills which might reduce the relapse. There is another reason to keep in touch in a systematic way, and that's if the person has some ongoing problems or symptoms. You've done a period of therapy, they have reached a certain level, and then you want to give them time to try those skills by themselves. And in many occasions, I've seen that whatever is the remaining problems, people are able to resolve by use of skills. But we bring them back at specific periods of time, or if there was a opportunity like using system like Tranquil, they don't even need to come back. You can see them at a distance and provide that kind of very targeted help for those things which are still kind of bubbling away in the background, even though bulk of the work is done in the active therapy session. So for some more chronic problems, that's kind of an approach which is helpful.
Thank you so much for your time, Dr. Rao. With this question, we are going to close this interview. It was such an interesting time that I spent, like a lot that I learned, and I hope it will be useful to our audience as well. And with that, if is there anything like closing note that you want to mention? Otherwise, I just appreciate your time and the knowledge that you shared with us.
No, I'm very happy that we had the opportunity to speak, and I'm very happy to use the Tranquil interface, which was really, I didn't sort of have any glitches or problems in actually interacting this way. But also the questions are also helping me think through what are the issues which might be coming up as questions in minds of patients and new therapists too. Especially when they're using video interfaces like this, which is the order of the day in a big country like Canada, where distances are a huge problem. So I've really enjoyed this time and working with you.
Thank you.
Thank you.
Have a great day.
Yeah, you too.